Bismillah ar-Rahman ar-Rahim. The role of MRI with the histogram analysis in monitoring therapy in patients with rectal cancer. Advances in the multimodality treatment strategies over the past decades have contributed to an improvement in the outcomes of patients with rectal cancer. The combination between the adjuvant chemoradiotherapy and the standardized surgical technique, meaning the total mesorectal excision, has led to an improvement in the local regional control, with local recurrence rate dropping from 20 to 30% to about 7 to 10% of patients with local advanced rectal cancer. Despite advances in the multimodality treatment strategies, there is still a considerable variation in response to the adjuvant chemoradiotherapy. Accurate prediction of response to therapy enables early stratification of management according to good responders or poor responders in order to adapt treatment to improve therapeutic outcomes in the rectal cancer. We have different methods of monitoring therapy on those patients, including both morphologic-based studies as well as the functional-based studies. The morphologic-based studies includes the conventional rectal MRI, the dynamic contrast enhanced MRI, and MRI perfusion. And the functional-based studies includes the MRS, PET-CT, PET-MRI, and the diffusion, of course, the diffusion histogram analysis. There are different systems that can be used to monitor therapy management in the patient of rectal cancer, including the WHO, the RECIST, and the modified RECIST criteria, as well as the more modified staging system, especially for the patients of rectal cancer, including the MRI tumor regression grade, which categorizes our patients into 5 grades from 1 to 5 according to the presence of fibrosis or mucin production, denoting good therapy response. However, we can find some situations in the basic morphologic or functional imaging cannot solve our problems. The volumetric measurements, which is the conventional measurements based on the standard morphological MRI, lack the sufficient accuracy for differentiation of treatment responders from non-responders because of their inability to detect small residual tumor within areas of radiation-induced fibrosis. Hence comes the role of the functional MRI sequences, which can enable us to assess the different biological tumor characteristics. Also, they have a significant correlation with the survival outcomes. The diffusion imaging develops image contrast through the inhibitory effect of cell membranes on the mobility of the water molecules in tissues. The malignant lesions display dense cellularity, restricting diffusion, and display low mean EDC. The EDC has been used to characterize tumors and quantify treatment-induced changes, and that may occur earlier than the conventional morphologic changes. In addition, the histogram analysis of the EDC can evaluate the biologic heterogeneity of a tumor by classifying domains of different diffusion restrictions, and this may have both prognostic and predictive implications. And to make it simple and easy, this is the conventional method of measuring the diffusion restriction in the tumor, where any radiologist can pick only a small dot. You can see the small circle here. This is the small circle where we can see the diffusion restriction on the tumor and measure the EDC value. And this circle can be different from one radiologist to another. This can lead to different in our measurement, our judgment of the case that can be different from one radiologist to another. The diffusion and the EDC data can be transferred into a DICOM format and processed with a specific software. This can enable us to perform a VOI, which is called a volume of interest. Not only one dot or one spot of the tumor that can be judged. We can judge the whole tumor. So the VOI can be manually created on the EDC maps, drawing regions of interest along the margin of the tumor using all slices of the tumor. This we can do a whole lesion measurement, a whole lesion interrogation. Within this VOI, the following parameters can be calculated: the EDC mean, max, minimum, median, mode, and also the different percentiles, as well as the different histogram parameters like the skewness, kurtosis, and entropy. And this is called the data mining. I'm not only measuring just a dot or a small area of the lesion. I'm measuring the whole lesion to get different values that can enable me to judge the whole tumor. This is a practical picture of what we do. We can interrogate the whole tumor. This is in purple here. This is the whole tumor in restriction, and we do the histogram. This is the drawing, the histogram that comes into our monitor, and it gives us a lot of information about the tumor. Not only the mean ADC, we can get different values of the tumor, including the mean, the different percentiles, and the skewness and the kurtosis of this histogram. This is the different parameters that can be found in the histogram analysis. This is another case. We are drawing along the whole margins of the tumor, and then we can measure our histogram and get our values. Another case here, this is the histogram analysis of the lesion we can draw, which is in blue. Here, the whole lesion is drawn, and then we get our histogram and different parameters which enable us to better judge the tumor. The histogram analysis is a promising imaging analysis technique which issues every voxel of region of interest into histogram, and therefore information regarding tumor homogeneity, heterogeneity can be obtained. By using this approach, more associations between the histopathology and the ADC values can be identified, which might not be found with the conventional ROI-based analysis alone. The main role of the histogram is to monitor the therapy. We can see in this case, this is the upper row, the pre-treatment rectal cancer in the axial planes, and the lower row is the post-treatment. We can see there is a reduction in the tumor volume. There is a reduction in the tumor volume. You can see this is the tumor. It showed a reduction in size, the reduction in the diffusion restriction, and this also correlates with our histogram, where there is a shift to the right on our histogram denoting good response. Another similar case, there is in the upper row, there is a lesion here in the pre-treatment, and in the post-treatment, we can see there is a good response with the reduction of the volume of the tumor, and this also correlates with our histogram. As we can see, there is a shift to the right denoting a more high ADC values, including denoting good response, as well as the reduction of the kurtosis and the skewness of this histogram. Histogram parameters have a predictive value in assessing response to adjuvant chemotherapy compared to the histopathological tumor regression grade. We found that a stepwise increase in the histopathologic tumor regression grade after chemoradiotherapy led to a decrease in the height of the histogram peak and increase in the ADC with a right-sided shift. Recent studies found that the whole tumor ADC mean combined with the tumor volume was highly accurate for predicting pathological complete response. We had a local study in our mini oncology center where we enrolled about 40 patients with rectal cancer who underwent rectal MRI with diffusion pre and post chemoradiotherapy. We used the tumor regression grade as a gold standard for judging the tumor response. We classified our patients into three groups: disease progression, and complete response. We found that there was a very strong correlation between the changes in the tumor volume, meaning response, and the change in both the skewness and the kurtosis of the histogram. We will see our first case, which a 48-year-old female was diagnosed by adenocarcinoma. We can see the upper row here is the lesion in the pre-treatment, and the lower row here in the lesion in the post-treatment, where we can find there is a decrease in the tumor size, marked decrease in the tumor size in all planes, denoting good therapeutic response. Also, the axial diffusion images here show that there is a reduction in the overall diffusion restriction of the tumor, and this correlates with our histogram, where we can see there is a shift to the right side, denoting good response. Another case with adenocarcinoma, where also the patient had disease regression. We can see here in the upper row there is a rectal cancer with a good response depicted by reduction of the tumor volume in the both axial, coronal, and sagittal planes, denoting good response. Also, the diffusion images depicts a reduction in the overall diffusion restriction of the lesion, and also this was markedly correlated with our histogram, where we can see there is a shift to the right side as well as reduction of the peak. Another patient who had disease progression, we can see the pre-treatment row here. There is an increase in the tumor overall size, as well as the diffusion images revealed increase in the degree of diffusion restriction, as well as increase in the tumor size. And the histogram interrogation revealed no definite changes in the shape of our histogram or the parameters. Another patient with disease regression, where we can see also the patient unfortunately had an increase in the tumor size despite the chemoradiotherapy, as well as increase in the overall diffusion restriction, and also interrogation of the histogram revealed no definite changes in the histogram parameters. It's worth mentioning that some of our lucky patients had a complete response and was enrolled in the watch and wait program, including this patient who had a complete response. We can see a complete disappearance of the rectal cancer after the chemoradiotherapy. And the diffusion-weighted images revealed the complete disappearance of the areas of the diffusion restriction, denoting complete response. And all of our patients, of course, were confirmed by the endoscopy, and we can use the histogram in these patients for research. In conclusion, the ADC and histogram parameters extracted from the ADC images have a potential value in predicting outcome of therapy in patients with rectal cancer, and the histogram analysis of the ADC showed a good results in monitoring therapy of rectal cancer patients compared to the conventional techniques alone, moreover with predictive potential to predict therapy outcome. Thank you very much.
Thank you, Dr. Ahmed, for your very nice presentation. Please will postpone all questions at the end of this session. Thank you. Next presentation. Next presentation, Dr. Wafa Samir Tobia, consultant of surgical oncology and head of surgical department in Oncology Center. His topic: watch and wait strategy of rectal cancer.
مساء الخير. أنا بشكر حضراتكم لوجودي معاكم النهارده. أنا هتكلم على إيرا جديدة ابتدت تظهر اللي هي الواتش أند ويت استراتيجي فور ريكتال كانسر. ماشي. Introduction. Over the past 100 years, the field of rectal cancer surgery has undergone various surgical developments. In addition, there have been huge changes in technical and oncological aspects accompanied by preoperative chemoradiotherapy during the last 20 years. The introduction of the neoadjuvant chemotherapy has brought about the most innovative changes in the treatment of the rectal cancer. Neoadjuvant chemoradiotherapy, which is focused on the reduction, كان الهدف بتاعها الأولاني إن هو reduction of local recurrence. بس بعد كده has shown difference in the oncological outcomes according to the regression of various tumor after neoadjuvant chemotherapy, which influence the strategy of subsequent surgical treatment. لا مش يعني اتحولت بعد كده ان احنا نقدر نغير تفكيرنا في السيرجري اللي هنقدر نعملها بعد كده. Total mesorectal excision an approved standard surgical treatment for rectal cancer, but is associated with perioperative morbidity and impaired quality of life. Therefore, treatment strategies that is maintain quality of life without compromising oncological outcomes has gained attention gradually in the patient with complete regression after neoadjuvant chemotherapy from about 15% to 30% of patients. Organ preservation approaches such as local excision and watch and wait have been attempted based on the several studies reporting favorable oncological outcomes in this patient. Local excision is advantageous in that it confirms the pathological T stage. Pathological lymph node metastasis status, however, cannot be detected. Furthermore, some studies have reported that a long interval between completion of neoadjuvant chemoradiotherapy and surgical intervention improved the tumor response. Therefore, watch and wait with deferred surgery with close surveillance has recently gained more support. Various efforts such as total neoadjuvant therapy are being attempted to obtain complete response in patients. Watch and wait strategy have been suggested for patients with clinical complete regression. The watch and wait approaches was first introduced by هابر جاما. هابر جاما أول واحدة ابتدت تفكر في الواتش اند ويت الابروتش أو الاستراتيجي الجديدة سنة 2004 وعملت ابديتنج بعد كده للستادي بتاعتها في 2014. أنا من خلال محاضرتي ديت أنا مش هقدم حاجة، أنا هجيب الاستاديز اللي اتعملت على الواتش اند ويت على مستوى العالم اللي ناقشت كام نقطة كده في الواتش اند ويت اللي هنناقشها، عشان في كونتروفيرسي رهيب جدا ما بين الناس اللي بتأيد فكرة الواتش اند ويت والناس اللي بتقول لا الراديكاليتي أحسن في الريكتال كانسر. The watch and wait approaches was first introduced by Haber Gamma in patients with complete clinical response after neoadjuvant treatment. Actually, it is not no surgery but deferral surgery. Therefore, the watch and wait approach or non-operative management is a representative term currently. البوينتس ديت اللي هنتكلم فيها في الواتش اند ويت اللي هي السرفايفل، اللوكال ريجروسيس، السلفج، البيشنت سيلكشن، الكومبليت كلينيكال ريسبونس، الديستال ميتاستاسيس، الاوفر اول سرفايفل. The number of applications regarding watch and wait for rectal cancer has increased abruptly. Many studies have reported comparable overall survival with watch and wait and radical resection. However, a high local rigorous rate is the problem, and proper selfish management is the main concern in watch and wait approach. Adequate patient selection is necessary to achieve favorable oncological outcome. However, the appropriate definition and diagnostic method for complete clinical response have not yet been clearly. ودي من المشاكل الثانيه اللي بتقابلنا بعد اللوكال ريجروس. المشكله الثانيه ان احنا ازاي نقدر نحكم على complete clinical response. Indeed, advances in the local control have not translated into overall survival improvement, and many efforts have been made to improve distant metastasis control and overall survival and improve clinical response to the preoperative chemotherapy. الكومبليت انا هتكلم على الكام بوينتس اللي احنا دوسنا عليهم. الكومبليت كلينيكال ريسبونس. The assessment of complete clinical response is usually performed using ثلاث حاجات: a combination of digital rectal examination, flexible endoscopy, and magnetic resonance imaging. Although the experience and the accuracy of these techniques are increasing, the accuracy of diagnosis of complete clinical response is not satisfactory because the detection of the small foci or residual tumor cells or lymph nodes involvement is difficult with these techniques. دوت دياجرام بيوضح لنا الاكيورسي بتاع الثلاثه مع بعض اللي هو الديجيتال ريكتال اكزامينيشن والاندوسكوبي والام ار اي. لقينا when all 3 predict a complete response correct in about 98% في الحالات. when all 3 indicate residual tumors بنلاقي 15% منهم complete response. دي الشكل اللي بنشوفه بالاندوسكوبي في الكومبليت ريسبونس. وات از ذا كومبليت ريسبونس؟ بالاندوسكوبي بنشوف وايتنينج اوف ميكوزا، اسوشيتيف تلانجكتيزيا، سبت لوس اوف باليابيليتي، لايت ستيفنس، تيومر كان نوت بيت فيلد او سي. ده دياجرام بيقارن ما بين الكومبليت كلينيكال ريسبونس والباثولوجيكال كومبليت ريسبونس. consistency between pathological and clinical complete tumor regression. It showed various description among studies. في studies كانوا قريبين قوي من بعض وفي studies تاني كانت في variation ما بينهم وبين بعض. How can we improve the complete clinical response؟ ما دام هنشتغل على الواتش اند ويت. طبعا النيو ادجفانت كيموثيرابي الستاندرد ريجمنت بتاع النيو ادجفانت كيموثيرابي اللي هو بناخده من 6 ل 8 ويكس بيجيب نتائج كويسه قوي في حوالي 27% ونص من الحالات. ابتدوا يزودوا الراديوثيرابي وابتدينا نزود لغايه 9 ويكس ونزود الدوز بتاع الراديوثيرابي، ابتدت النتيجه ترفع معانا توصل لغايه 54%. بعد كده عملنا حاجه اسمها اكستندد ريجمن، بنزود كمان كيموثيرابي increased the rate of complete response to neoadjuvant chemotherapy for distal rectal recurrence rectal cancer. Results of the prospective study using additional chemotherapy during the resting period. في فتره اللي هي بعد ما بنخلص النيوادجفانت كيمو راديوثيرابي، بدل ما بنستنى في الريست بيريود ابتدينا ندي كيموثيرابي تاني الاكستندد كيموثيرابي. ابتدى يظهر نتائج ضعف الكومبليت كلينيكال ريسبونس اللي كان بيبان 32% مع الستاندرد كيموثيرابي، ابتدى يوصل لغايه 62% في بعض الدراسات اللي معموله انه يوصل لغايه 62% كومبليت كلينيكال ريسبونس. كونسوليديشن كيموثيرابي كمان ابتدى يحسن اكتر واكتر الريزلتس بتاع الكومبليت كلينيكال ريسبونس. ان اديشنال كونسوليديشن بيتر ذان نو كونسوليديشن كيموثيرابي. مور كيموثيرابي النتيجه اللي وصلنا لها بعد الريجيمين والاستخدامات دي هو ان مور كيموثيرابي مور باثولوجيكال كومبليت ريسبونس. الستاندر، فرق بين الستاندر والاكستندد والكونسوليديشن النتائج بنبص نلاقي في فاريشن كبير جدا ما بينهم. not all patient achieve a complete clinical response at the same time. ده التشالنج اللي بتقابلنا في الكومبليت كلينيكال ريسبونس. يعني الانترفال ما بين الكيموثيرابي بعد ما بخلص الكيموثيرابي وما بين اقدر احكم ان ده حصل له كومبليت كلينيكال ريسبونس. الناس ابتدت، احنا كنا في الاول بنقول من 6 ل 8 اسابيع، بعد كده دلوقتي ظهرت النتائج ان بعد من 10 ل 16 اسبوع 37%، لو استنينا اكتر من 16 اسبوع ممكن نوصل ل 73%. الصوره دي بتاعت هابر جاما. هابر جاما بتستنى على العيان لغايه ما يوصل 52 اسبوع، سنه كامله وهو في ريزيدوال، بتفحصه ريجولاري ان هو ما فيش بروجريس، ولو في ريجريس او في ستيشنري كورس بتوصل معاه لغايه ما يوصل سنه. يعني جايبه صوره الواحد ده بعد ال7 ويكس وده بعد ال52 ويكس، يعني بعد سنه كامله حصل كومبليت كلينيكال ريسبونس. فهي عشان متحمسه قوي نظريه الواتش اند ويت، فهي يعني عاوزه توصل ان احنا يعني هو حتى اتسالت في النقطه دي، طب انا يعني اتابع العيان ازاي؟ السيرفيلانس اللي احنا هنعمله كل 3 شهور، قالت طول ما عنديش بروجريشن في الديزيز انا ممكن استنى معاه لغايه ما يوصل لغايه 52 ويكس. ممكن تكون المعلومه دي مش كتير اللي هيتقبلها مننا. Many studies compared the oncological outcomes between the patient who underwent watch and wait and those who underwent radical resection. هنا دي جداول طبعا جايبه الاستاديز كلها اللي طبعا ابتدت بهابر جاما 2004 وطبعا عملت ابديت هي بعد كده في 2014 بتقارن ما بين اللوكال ريكارنس والديستال ميتاستيس واللوكال ريجروس والكانسر ديس والسالفج في اللوكال ريكارنس. اللوكال ريجروس ذا بيزد اون ذا بريفيوس ستادي. انا عشان الوقت اللوكال ريجروس يعني اتضح ان هو اللوكال ريجروس مع الواتش اند ويت ازيد طبعا من اللوكال ريجروس مع الراديكال سيرجري او اللوكال ريكارنس بعد الراديكال سيرجري. في الواتش اند ويت بيوصل من 3.3 في بعض الاستاديز زي بتاعت هابر جاما لغايه 30% في استاديز ثاني، لكن بالنسبه للراديكال سيرجري من 0 ل 2.2%، واكثر نسبه بتوصل فيها اللوكال ريجروس بيوصل في اول 3 سنين. اول سنه طبعا الماجوريتي بتاعتها بتوصل في اول 3 سنين. دي انتراليومينال طبعا هي يعني 90% من اللوكال ريجروس بيحصل انتراليومينال، يعني لوكالي انتراليومينال نقدر نتعامل معاه بسالفج سيرجري. هنا اللوكال ريجروس ماجوريتي هابر جاما طبعا 3%، اخر استادي هنا 22%، ان اللوكال ريجروس بيتراوح ما بين 3 ل 22% بعد الواتش اند ويت. السكيم دوت بيبين ان اول سنه بيحصل فيها 65%، ثاني سنه بتوصل ل 23%، 12%، يعني اكتر سنه بيحصل فيها اللوكال ريجروس اول سنه، وتاني سنه بيبقى يعني النسبه بتبقى اقل، وتالت سنه بعد كده لو ما حصلش لوكال ريجروس لفتره طويله هي بتعتبر كده ان هو العيان ده ممكن يبقى كيورد، يعني ممكن يتابع لفترات طويله من غير لوكال ريجروس. او هم بقى التشالنج الثاني اللي بتقابلنا في الموضوع دوت، ايه البريدكتيف فاكتورز اللي اقدر احدد عليها او اقدر اشتغل عليها عشان اوصل لكومبليت كلينيكال ريسبونس. ما فيش حاجه قدروا يوصلوا لها غير التي ستيج، لكن ما فيش ستاديز ثاني اتعملت على اي حاجه ثاني، حتى السيركيوليتنج سيركيوليتنج تيومر دي ان ايه لسه ما فيش على استادي واحده بس اتعملت عليها، وما فيش حاجه استابليشد بالنسبه لها. هنا بيبين ان الفرق في التي ستيج هو اللي بيفرق معايا في اللوكال ريجروس، ان تي 1 وتي 2 بتوصل ل 19%، تي 3 31، تي 4 ل 37%. طبعا ديت الريجروس دي الاستادس، يعني انا الدياجرامات دي بتاعت استادس مختلفه. يعني organ preservation and salvage according to the studies the following local rigorous the pooled proportions of patient which had salvage therapy was about 90%. Sphincter preservation was achieved in about 50% of patients undergoing salvage surgery. وهنا طبعا الاورجان بريزرفيشن عند هابر جاما في 2004 100% حصل لهم اورجان بريزرفيشن. طبعا في الاستاديز الثانيه كانت النسب اقل. طبعا هنا ديت الصوره بتاعت هابر جاما ان هي بتوصل ل 93%. انا مدقق قوي مع هابر جاما عشان هي صاحبه الفكره، هي البايونير في فكره الواتش اند ويت، وهي اللي شغاله عليها لغايه دلوقتي. 93% من العيانين اللي عندها قدرت تعمل لهم سالفج. ده برضو دراسات والفرق ما بينهم. distal metastasis. However, in the patient with complete clinical response, distal metastasis following the watch and wait was reported to be comparable to that after radical resection in patient with pathological complete response. بس برضه الاستاديز وضحت ان مفيش فرق جامد جدا في الديستال ميتاستاسيس ما بين اللي عمل راديكال سيرجري واللي عمل واتش اند ويت استراتيجي. يعني هنا بتجيب النسب مثلا الريت بتاعه الديستال ميتاستاسيس اقل، برضه الريت بتاعها قليل. الكومباريزون ما بين الاثنين ستاديز الواتش اند ويت اند السيرجري نو ديفرنس كتير في الديستال ميتاستاسيس. السرفايفل مفيش ديفرنس برضه في السرفايفل ما بين الناس اللي في الواتش اند ويت اند الراديكال سيرجري. هو كل الديفرنس اللي كان موجود بس في اللوكال ريجوروس. هنا السرفايفل برضو وصلت لنفس يعني نفس النسب او نفس البرسنتج بتاعت الستاديز ديت زي الراديكال سيرجري زي الواتش اند ويت بالظبط. مفيش ديفرنس ما بين الستاندرد ابروتش فيرسس واتش اند ويت في السرفايفل. السيرفيلانس اهم حاجه بقى برضو التشالنج الثاني، احنا هنتابع كل قد ايه وهنعمل ايه. هنا هنتابع كل 3 شهور، اول سنه كل 3 شهور بنعمل فحص بي ار والكولونوسكوبي والام ار اي بتاعنا والسي تي طبعا. تاني سنه بنعمل الفحص كل 3 شهور، يعني ده السكيما بتاعه الفحص. اول سنه بنعمل كل 3 شهور الديجيتال ريكتال اكزامينيشن والام ار اي والاندوسكوبي. تاني سنه بنعمل الديجيتال ريكتال اكزامينيشن كل 3 شهور، لكن الام ار اي والاندوسكوبي بنخليه كل 6 شهور. ثالث سنه نفس الكلام. رابع سنه بنخلي الديجيتال ريكتال اكزامينيشن والدلالات والسي اي كل 6 شهور، وبرده الام ار اي والاندوسكوبي كل 6 شهور. لازم يبقى كلوز اوبزرفيشن وكلوز سيرفيلانس للعيان. بعد 5 سنه ممكن بنعمل الديجيتال اكزامينيشن كل 6 شهور والام ار اي وبرده الاندوسكوبي كل 6 شهور. ديت من الناس اللي هي مش قابله فكره الواتش اند ويت، حطت شويه ليميتيشن اوف واتش اند ويت ابروتش. نو اكزاكت كورليشن بتوين كومبليت كلينيكال ريسبونس وباثولوجيكال كومبليت ريسبونس. السيلف سيرجري بيقول ايوه فيها هاير ريت اوف ابدومينال ريسكشن about 50%. هاي لوكال ريكارنس افتر واتش اند ويت. نو بروسبكتيف ايفيدنسز، نو وايدر كلينيكال ابليكابيلتي. لسه ما فيش ستاندرايزد للبيشنت سيلكشن او نيو ادجفانت ثيرابي ريجمنت دايجنوستيك تكنيك فور ريسبونس اسسمنت. ديفينيشنز اوف لوكال ريكارنس اند فولو اب. دي التشالنج. بس برضو الناس الثانيه بترد عليهم بتقول لهم التريتمنت بالراديكال سيرجري عند الموربيديتي ممكن توصل 38%، مورتاليتي 2 ل 3%، يورينال ديسفانكشن 20%، باقي كل الاستوما مثلا اكتر من 50%. لما عملوا دراسه على الاكسبكتيشن بتاع العيان والعيان عايز ايه اساسا، اتضح ان معظم العيانين اللي هو باين باللون الاورنج اول صف كلهم نوستوما. دي نمره واحد، رغبه العيان نوستوما حتى لو مش هيبقى فيه كيور. نوستوما دي نمره واحد. اي عيان بنساله بيبقى فعلا حكايه الكولوستوم الحكايه دي صعبه بالنسبه له، والكيور ونو كومبليكيشن بعد كده تيجي في الترتيب. ال NCCN جايد لاين في 2020 كونسينز based guidelines from NCCN status that is for patient who achieve a complete clinical response with no evidence of residual tumor on digital rectal examination and rectal magnetic resonance imaging and direct endoscopy, an initial inoperative approach may be considered with an experienced multidisciplinary team. وده ال NCCN جايد لاين. والجمله اللي انا كنت كاتبها فوق ان هو ابتدى يقبل فكره الواتش اند ويت استراتيجي دي، ان احنا الواتش اند ويت استراتيجي لازم اشرح للعيان الريسك اللي ممكن يبقى فيه من اللوكال ريجروس، والريسك ان احنا ممكن ندخل على جراحه الراديكاليتي فيها اكبر من الاول. rectal cancer watch and wait strategy sustained complete clinical response is almost cure. Most patients with rigorous are salvageable. Careful patient selection and close monitoring are the key. A high proportion of patients can achieve organ preservation. Excellent service. Thank you.
Thank you Dr. Wafaa about this eminent session talk. هستأذن احنا نأجل الأسئلة لآخر السيشن.
Okay.
Now with Dr. Sara Di Dosso from Switzerland, we'll talk about new insights into adjuvant treatment for colon cancer.
we are awaiting for the link to open with Dr. Sarah De Dosso, so we will shift to the supposed to be last session. Dr. Miriam from Georgia. I failed by all means to pronounce your title, so I mean your last name, because just we are here to wait your session. Please, Dr. Miriam. Dr. Miriam, as I can pronounce it, Kukhalashvili. If it is okay, I don't know if it's right or wrong. And she will present sidedness in advanced colon cancer.
Thank you so much.
Dr. Sarah, please.
Good evening, everyone. It's my pleasure to be here. It was my dream to come to your country on this conference, and thank you for inviting me here. My name is Mariam Kukhalashvili. I am from Georgia. I am clinical oncologist and working in the largest chain of hospitals in Georgia. Today my talk is about the sidedness of colorectal cancer. It's a very important part of our field because it is the third most common diagnosed cancer in European countries. This diagnosis has the different, it's very heterogeneous and has a different outcome, and the biology and markers, prognostical and predictive markers are different between left and right-sided colorectal colon, and let's start from the beginning with anatomy. First question is what is the right and what is the left? We are at the midpoint between them. The midpoint between left and right-sided colon, it is a splenic flexion. And to the right, it is a proximal part, and to the left, it is a distal part. And the vascular supply, we know from the embryology that these two parts of colon has absolutely different origination, because the left-sided colon arises from the hindgut and right-sided colon arises from the midgut. And vascular supply is also absolutely different, because midgut supplies upper mesenteric artery supplies midgut, and inferior mesenteric artery supplies hindgut. Next difference between right and left colon, it's a microbiota. We know that colon is very rich with microbiome, and these two parts of colon has different concentration of microbiota. And also, this microbiome includes bacteria which are very important and which are associated with development of colorectal cancer. Also, biofilms, invasive biofilms. It's very interesting that it is mucose layer on the topic of the mucous membrane, and in 89% of right-sided colorectal cancer was found this microbiome, and in 12% of left-sided colorectal cancer cases was also found. Next difference is it is a bile acid. We know that bile acid and its metabolite products has carcinogenic activity, and the concentration of bile acid are different between left and right-sided colon. And if we are talking about the different carcinogenesis between right and left-sided colon, one explanation could be this bile acid and its components. Yes, methylation factor. Hypermethylation, it's a problem of right-sided part. And hypermethylation, it is not statistic process. It changes by age. And we can say that a colon does not age by the same way. And the genetical factors is also different between left and right-sided colon. Right-sided colon is more commonly has a BRAF mutation, it has a KRAS mutation, high MSI status. Also, clinical manifestation is different. In this part of colon, we have less differentiated tumors, and this diagnosis, right-sided colorectal cancer, is common in females in older age, in contrast with left-sided colon, when we have KRAS wild type, mostly we have KRAS wild type, BRAF wild type, HER2 amplification, and this diagnosis, left-sided colorectal cancer, is more common in younger age. Also, metastasize has different. Right-sided colon metastasize mostly to the peritoneum, and left-sided colorectal cancer metastasize to the thorax, and less common to the bones. Pre-malignant lesions. Different signaling pathways are also involved in development of colorectal cancer. We have several types of pathways, conventional pathways, serrated and familial pathways. For right-sided tumors, serrated pathways are more common in contrast with left-sided, where we mostly have conventional pathways. And colonoscopy is also good standard for treatment patient with adenomas, with premalignant lesions. Does this matter for early stage disease? The answer is no, because with the data which we have up to now, the sightness is not a prognostical parameter for early stage disease for stage 1, 2, and 3 colorectal cancer patient. It is prognostical factor for stage 4, and the question side does not matter in metastatic disease. Yes, it is a prognostical factor. We have several clinical trials. Very beginning, before some decades ago, you can see our first trial. I love this trial very much because in this trial, E2219, well enrolled more than 100 patients, and some decades ago, sightness was involved in the clinical trial parameters as a prognostical factor. In the next trial, CO17, it is a last line of treatment colorectal cancer, best supportive care versus cetuximab. You can see that sightness is a prognostical parameters, and below you can see the patient with treated with cetuximab, left-sided cancer. They have better outcomes in contrast with right-sided colorectal cancer. Next question: which biological factor, which biological treatment could be offered patient in first-line treatment? And the answer is VEGFR or EGFR antibodies, anti-EGFR and anti-VEGFR antibodies. We have several trials, and one of them is FIRE-3, phase 3 trials, and according to this trial, you can see that right-sided patient treated with cetuximab had worse prognosis in contrast with left-sided colorectal cancer treated with cetuximab. Median overall survival for patients with left-sided colorectal cancer treated with cetuximab is at 38.7 months in contrast with right-sided tumor treated with cetuximab. It is the duration is 60.1 months. We can say that clinical trial CALGB SWOG-8045 also demonstrated the same parameter, the same result. Cetuximab works and has better outcome and effect in treatment with patient with metastatic colorectal cancer, mostly left-sided colorectal cancer. What about the bevacizumab? Bevacizumab is effective in both-sided tumor treatment. We can make very small conclusion that cetuximab should be a first-line option, first-line treatment recommendation for patients with left-sided tumors. Of course, this cancer could be a BRAF, KRAS, and NRAS wild type. What about the ESMO and NCCN recommendations? According to the ESMO guideline, we have the recommendation that EGFR should be the first choice of treatment for left-sided tumor, BRAF, NRAS, and KRAS wild type. And in the NCCN guideline, we cannot find direct, clear recommendations about the sidedness treatment. Not only sidedness is important. We know very well that patient comorbidities and also preferences and tumor biology and the side effects, many other factors should be considered to make resolution about the first-line treatment choice. For us, it's very important to distinguish what we want to achieve with our treatment strategy. Do we need intensive therapy? Do we need gel therapy? What is our goal of palliative treatment? In this beautiful conclusion, I want to summarize my talk and explain that right-sided tumor should be offered treatment with chemotherapy plus bevacizumab. Left-sided tumor, it's better, it's preferred to recommend EGFR inhibitor plus chemotherapy. And MSI high tumor, mostly this tumor is right-sided, BRAF mutated, should be enrolled in clinical trials and recommend immunotherapy. And BRAF mutated tumors, it's preferred to recommend triplet chemotherapy. Thank you so much.
Thank you, Dr. Mary, about this eminent talk.
Thank you so
ممكن
much.
نفتح الأسئلة لو حد عنده سؤال. Any questions?
I want to ask one question about the incidence of colorectal cancer at the right side, ascending colon. What about the role of exposure to the bile in increasing incidence of cancer colon right side?
I cannot understand the question once again, please.
Some studies say that colorectal cancer or colon cancer in right side increase the incidence by exposure to bile, more bile in the right side.
Yes.
What about this? What is the news?
Right-sided, you mean, yeah? Right-sided, the midpoint is splenic flexion, and to the right it is the right-sided, but 1/3 of transverse colon is a left-sided, and 2/3 of transverse colon is left-sided. We can say that the transverse colon has mixed embryological origin, and that's why transverse colon was excluded from the several clinical trials. I think it was your question or not. Thank you so much.
Thank you, Dr. Mariam. It's an honor to introduce Professor Dr. Sarah Di Tosso from Switzerland. She will us talk about new insights into adjuvant therapy of colon cancer. Please, Dr. Sarah.
Do you hear us, or we are not clear to you, Dr. Sarah?
I am unmute and I am speaking.
Yes. Can we elevate the voice a little bit, please?
Can you hear me?
Yes, now we are hearing you 505. Please go. Yes.
Wonderful. Thank you very much for your invitation. It is really very kind, and for the nice introduction. It's really a pleasure to join you, even though virtually from Switzerland. So congratulations for this event. I am going to share my screen. Can I have the opportunity to share my screen for the presentation? Because
Allow sharing
okay.
screen, please.
Now
on the
it
side.
works. Perfect.
Yes.
And okay. Okay, do you see my full screen?
Perfectly.
The full screen without the notes.
Yes, yes,
Yes,
perfect.
okay,
Yes.
it works. Thanks. Okay, so let's start with my presentation. The aim of my talk is to present to you the new insights into adjuvant treatment of colon cancer. Here are my disclosures. And so we know that surgical resection of the localized colon cancer is the only curative option. And without an adjuvant chemotherapy, around half of all patients will finally relapse due to micrometastatic spreading. Adjuvant chemotherapy has a relatively low absolute survival advantage, around 25 to 30%, but the risk of adverse event. So this is the reason why we need accurate patient selection, key of the adjuvant strategy, to avoid unnecessary chemotherapy exposure and to improve patient selection, and also to avoid unnecessary toxicity. Namely, we know that neuropathy is one of the main toxicity that can upset our patient and can persist also after several years from the termination of an oxaliplatin-based chemotherapy. You can see the final result of the long-term safety results of the MOSAIC trial, where you can see that there is a persisting neuropathy also after 2 years or after 4 years from the end of the treatment. So the first strategy would be to reduce the chemotherapy exposure without affecting the final outcome. So this is the strategy from the IDEA collaboration, where 3 months of oxaliplatin chemotherapy was compared to a 6 months treatment that was the standard of care. And you can see that according to the outcome, 3 months capox, so 3 months of an oxaliplatin-based treatment has been demonstrated as non-inferior in comparison to a standard 6 months in low-risk colon cancer in stage 3, so this means T1, T3, T3, and N1 disease, so according to the pathological results. On the other hand, in high-risk stage 3 colon cancer, the non-inferiority of 3 months of oxaliplatin-based regimen in comparison to 6 months has not been demonstrated. And in addition, if we look at the toxicity profile, moderate or higher grade neuropathy with 6 months oxaliplatin-based chemotherapy has been demonstrated in 45% of patients versus a 15% of incidence in patients treated with a 3 months oxaliplatin-based strategy. So this means that in low risk stage 3 colon cancer patient, we are allowed to consider a 3 months strategy with an oxaliplatin based regimen in order to decrease the incidence of neuropathy. We have a 30% decrease in neuropathy and without affecting the final outcome results. So, in any case, according to the ESMO guidelines, the rationale is that the patient with a higher risk of recurrence can obtain a greater benefit from an adjuvant chemotherapy. So the TNAIM staging remains the most relevant criteria, an histological criteria for the risk assessment. TNMA staging, but there are also other clinical pathological characteristics in stage 2 and the MSI high status in stage 2. But we have also to consider when we are deciding about a chemotherapy, an adjuvant chemotherapy after surgery, the risk assessment of complication from adjuvant treatment according to some clinical characteristics such as, for example, the echo performance status, the age of our patient, other comorbidities, or also according to DPD genotyping. So I am sure you are all quite familiar with this algorithm from the ESMO recommendations in stage 2 and 3 colon cancer in considering adjuvant chemotherapy. And according to this algorithm, so considering the recommendation according to the TNAME status, we can obtain a 3 to 5% absolute survival benefit in high-risk stage 2 colon cancer patient with the addition of a single agent 5FU. And in stage 3, we have an absolute survival benefit of around 10 to 15% with 5FU alone, with a further 5% improvement with an oxaliplatin containing combination. So this means that the clinical outcomes can be very different among patients with the same stage, and more than 70% of patients, so in green and in red, receive chemotherapy without benefit and with toxicity. So the aim for the future research strategy is to improve this current 20% of patients who are cured with adjuvant chemotherapy, so this blue population. And a personalized medicine is the key also in adjuvant setting to define the prognostic groups and to find predictive markers of benefit of an adjuvant chemotherapy. So currently, the most promising tools for a personalized adjuvant strategy are gene expression signatures, the immunoscore, and liquid biopsy that I can spoiler you that to my view is the most promising tool. So gene expression signatures are multi-gene assay systems developed to evaluate the recurrence risk in patients with colorectal cancer. So just to mention, Oncotype DX or Coloprint can be prognostic, but there is a clear lack of evidence of their predictive value. So in this particular setting, I would like also to mention the consensus molecular subtypes, the acronym is CMS, that are based on differential gene expression in tumor site, comprising both cancer cells as well as the microenvironment. So at the end, this classification can obtain 4 subtypes and can be potential for clinical use in predicting both prognosis and response to systemic therapy. So you can see a pooled analysis of 4 main retrospective studies analyzing this particular tool of the classification in the 4 CMS classification. And you can see that at this retrospective analysis, adjuvant chemotherapy in stage 2 and 3 colorectal cancer seem to be most beneficial in CMS2 and CMS3. You can see the blue and violet groups, and on the other hand, seems to be not effective in CMS4 group in green. You can see that there is on the part which is in favor of surgery alone. But of course, as I mentioned before, these results are based on a retrospective analysis, and so we need more prospective studies also with stratification of the patient according to this group to really understand the role of this CMS taxonomy in clinical practice. And the other scoring system is immunoscore that is based on density of CD3 and CD8 T-cell effectors within the tumor and the invasive margin using a particular digital pathology paraffin sections. So it's something that can have a good reproducibility. Has been demonstrated to have a prognostic role, but its predictive value
is still uncertain and maybe could be useful in the implementation of immuno-oncology trials in adjuvant setting, but it is still under development, and probably we can hear about it in the future. As I have spoiled before, in my view, the liquid biopsy represents the most promising tools. We know that ctDNA analysis is directly evaluated for the evidence of the minimal residual disease after radical surgery. So we already know that ctDNA analysis is useful in identifying this MRD after surgery. So it has also been demonstrated that its prognostic role. We know that 80% of patients with positive liquid biopsy will relapse, but 20% will not. So probably there is something that still should be better understood, and 10% of patients with negative liquid biopsy will finally relapse. In addition, its predictive role is still under investigation, and with this regard, I would like to briefly mention you the results of the dynamic trial. These results were presented at the latest ASCO 2022, and immediately after the presentation were also published on the New England Journal of Medicine. So this trial included patients with a resected stage 2 colon cancer, and patients according to the ctDNA status were randomized to a standard management or a ctDNA guided management according to the ctDNA status. So ctDNA positive patients were treated with adjuvant chemotherapy, and the ctDNA negative patients were also observed. So just to remind you, stage 2 colon cancer. So the methodology was a tissue-based strategy. So it was a really highly personalized treatment because ctDNA probes were personalized on the basis of specific mutations identified in tumor tissue. This means high personalized strategy, high sensitivity, but on the other hand, this procedure took quite more time to be finalized. So patient, for example, treated with ctDNA positive and treated with adjuvant chemotherapy started the adjuvant treatment around at 11 weeks in comparison to the maximum of 8 weeks that is accepted as a standard practice. The primary endpoint was a relapse-free survival rate at 2 years. And, the key secondary endpoint was the proportion of patients receiving adjuvant chemotherapy. If we look at this late key secondary endpoint, it is pretty clear that there is a less chemotherapy use with a ctDNA-guided management. And this is really clear in T4 tumors and in poor differentiated tumor. And on the other hand, there is a less chemotherapy use with the standard management in patients with an age of more than 70 years old and in case of resection of less than 12 lymph nodes. And concerning the primary endpoint, you can see the relapse recurrence-free survival curves, and it is pretty clear that a ctDNA-guided approach to the treatment of stage 2 colon cancer can reduce the use of adjuvant chemotherapy without compromising the recurrence-free survival. You can see that there is no statistically significant difference between the two curves. And of note, it is pretty interesting that if we look at the relapse-free survival according to the ctDNA status for the ctDNA-guided arm, you can see that there is really a favorable 3 years relapse-free survival in patients with a positive ctDNA treated with an adjuvant chemotherapy in comparison to historical serious, more than 80% in comparison to 20% from historical serious, where in the majority of cases patients were not treated with chemotherapy. So in conclusion, which are the future perspectives with the use of liquid biopsies? First of all, we need further advances in technology to improve the sensitivity and method standardization. So we need to use tissue agnostic strategies, reducing the time to obtain results, and also epigenomic signatures related to, for example, aberrant DNA methylation. So improve the technology and the method standardization. And the question is if the minimal residual disease can be treatable also in colon cancer. And the question is if chemotherapy prevent or just delay relapse in ctDNA positive patients. Of course, we need more evidence to give an answer to this statement. And the question is also if we can de-escalate chemotherapy in ctDNA negative patients. So a ctDNA monitoring during the chemotherapy, and if there is a real subgroup of patients, of ctDNA positive patients, who can really benefit from chemotherapy, and which kind of chemotherapy. Is oxaliplatin really necessary in this particular setting, or for example, 5-FU alone can be enough? And how to deal, for example, with patients with a high-risk pathological factors according to the TNM classification, but ctDNA negative. This is also an open question. And of course, also health economics evaluation will be crucial for the future. So for the future, we are really curious to see the results from several trials that are currently ongoing for specific subgroup of patients of colon cancer. So for example, adjuvant immunotherapy plus or minus in addition or minus chemotherapy in MSI high instability colon cancer. And of course, there are currently ongoing several trials with a ctDNA guided approach in deciding the adjuvant chemotherapy. So stay tuned for the future, because I see really several new data that will necessarily also have an impact on our clinical practice. So thank you very much for your attention.
Can we have a question or two from the floor before ending the session? So, Dr. Sarah, if I may ask you, I'm a clinical oncologist, and those trials, especially the ongoing ones, are having some heterogeneous groups of patients. We, in the last presentation, have been listening to the sidedness, the right side colon and the left side. So not all the patients included or eligible to enter those studies are the same. Would it be an era of subdivision of the patient to find which patients are better to use this kind of treatment or not? Or you can find an answer for those patients, which patient fits which drug better?
Yeah, thank you very much for this interesting question. I think that it's really the most important point in adjuvant settings, such as, for example, also, of course, in metastatic setting. But whilst in metastatic setting, there is a great effort in trying to better select patients according, for example, the sidedness, the molecular profile. I have seen that, for example, in adjuvant setting, the current trials are not designed to do a stratification of patient according to some specific molecular characteristics. For example, during my presentation, I have mentioned the CMS classification. That is something of really very theoretical, but none of the prospective trial have never analyzed its role in a prospective treatment, so or as a stratification. So I have to say that it would be really interesting if there were also a selection of patients according to particular molecular tools, but to my knowledge, there is no a standardization of this criteria. So probably this will be an unmet need also in the future.
So thank you so much for your time. Hope next
Great
year you will
pleasure.
be not virtually, but physically present with us to enjoy this time of the year in Cairo, inshallah. Thank you so much for your time.
Fantastic. Thank you very much
Thank
to all of you,
Thank you
and
so
thank
much.
you, and see you soon and next time. Thank you.
Thank you.
Bye.
So,
Thank you.
Bye-bye. Bye-bye. So I think by that we can conclude this session. Thank you so much for the first session of colorectal. I think we are delayed enough to continue for the second session immediately. So I'm asking the chairpersons and the presenters for the second session. Thank you so much.